Good evening, everyone, and welcome to this special webinar event sponsored by Biodesics. Tonight, we will be discussing the importance of risk stratification in a structured lung nodule program. This is an expert panel discussion with Drs Mercado, Garwood, and Yuhico. Before we begin, just a few reminders to the audience and for anyone new to the SAB webinars. Everyone is currently in a listen-only mode and is muted. We do influence you to ask your questions throughout tonight's lecture. You may simply submit them by using your control panel where the question feature is located. We will address them at the end during our Q&A portion. At this time, I'm going to hand it off to Dr. Mercado, who will be moderating tonight's session. He is the chair of the SAB membership committee here. And we once again would like to thank everyone for joining and Biodesics for being SAB sponsors this year. At this time, I'll hand it off to Dr. Mercado.
Thank you, Emily. Good evening, everyone. Thank you for joining us on one of our ongoing SAB webinars. This time I'm accompanied by Dr. Susan Garwood from HCA Enterprise, as well as Dr. Luke Yuhico from White Wilson Medical Center in Florida. My name is Dr. Jorge Mercado. I'm an associate professor of medicine at NYU, and we'll be discussing today the importance of risk stratification in a structured lung nodule program, a discussion between the three of us that have been using different techniques, and we have all of us starting our own lung nodule programs with assistance from our own institutions, and kind of like the pros and cons of starting those. With that being said, I'm going to start the program by listing the discussions and the learning objectives for tonight. So we're going to be discussing the benefits and unintended consequences of implementing a structured lung nodule program, the importance of risk stratification to optimize patient pathways, and rationale for incorporating biomarkers, what is out there, and as well as the value of a standardized workflow for biomarker-based risk stratification. We want to keep the discussion really open to the public, so we're going to have discussion between the three panelists, but as well as the end of the program, there's going to be minutes for questions and answers. You're going to see a marker on your right side to list any questions you may have. We'll be more than happy to answer them if we have the time for it. With that being said, the first is that we all have disclosures for Biodesics, which is the sponsor. We thank Biodesics for sponsoring this program, and we're all speakers for Biodesics. So that without feeling disclosed, I'm going to go to my colleague, Dr. Garwood, to talk to us about her own experiences building a lung nodule program. To you, Doctor.
Thanks, Dr. Mercado, and thanks everybody for joining tonight. You see in the title of tonight's talk, it's a structured lung nodule program, and that's what the three of us really are hoping to share. So much less about the technology of the Biodesics platform, but how do we structure a lung nodule program? So each of us want to give you an idea about what our practice looks like. So I wear a couple of different hats. I am a dedicated proceduralist only. So I don't do any general pulmonary or critical care since 2015. So we have worked on dedicating a structured nodule program within my hospital, within my division. So I'm the thoracic oncology director for our division. So we have 9 hospitals in that. And then I also wear the national physician hat for all of HCA. So we had to launch all of our lung nodule programs from an incidental finding and a screening finding and come up with an algorithm. And most recently, after launching 128 programs, we've really circled back and realized that we need to do some fine tuning. And that fine tuning is risk stratification. How do we really make the visit most impactful? How often are our physicians in our nodule programs really doing this in a structured way? Do they have a workflow on how to interpret tests like Biodesics and how to influence their plan? So it really has been extremely helpful for us to have that structured conversation. When we talk about the number of nodules that come through within the HCA system, Luke is part of that. Last year, we looked at a little over 3.4 million scans to identify nodules. And you can imagine with that many nodules, if you aren't risk stratifying and separating the high and the low risk, you're really going to get underwater quickly. What we hope tonight is that you will ask us questions. You'll be candid. We all have run into a lot of barriers We all started, I think, very boldly thinking that we knew what lung cancer looked like. We all are proceduralists. We love doing procedures, but not every patient needs a procedure. So we want to be candid with you guys about our experience. And so with that, I will kick it to Luke, and maybe you can share your kind of practice design currently.
Thank you, Susan. So in my setup, it's sort of a community practice setup down in the Panhandle of Florida. It's an interesting story because if we were to look at my practice today and our program, you'd see a very robust program. So we have anesthesia support all year. You know, we do procedures every day. We have a bronchoscopy nurse, we have robotics, we have tumor board and nodule board, and we have all the components now that you'd see in the lung nodule program. However, the best part of the story, I think, is to note that we did not start like that. 7 years ago, when this all began, it was a small hospital with just me, and it was an area with big catchment. So I'm in an area where for about 3.5 miles and a drive, 3 hours left and right, there's not much pulmonary support, but we have a lot of nodules. It's Florida. So we have 2 military bases, we have a lot of smokers, but we also have a migration pattern from Ohio and Michigan. So we have a mix of granulomatous lung disease. And so at that point, the challenge was to organize a setup where we could properly stratify which patients went to procedure and which didn't. And over time, what we were able to do is basically use the tools we had. Some we had then and some came along the way, such as the blood tests, and properly allocate the nodules as to which were to go to procedure and which not, and show good return of investment. So by properly using risk stratification, we were able to prioritize our procedures. Like Susan said, we are all proceduralists, but it was about getting a high percentage of procedures with a high diagnostic volume of cancer that rolled down into surgeries, and we were able to bring that back to the hospital and grow our program over time. And so over 7 years, from something that was a small hospital with no dedicated organization, over time, it was able to grow into something fairly robust. And I think this is the message we want to share with everybody today. As you all look at your practices and build your programs, we wanted to stress on the importance of risk stratification, how to get it together, how to build it from the get-go, so that as your program grows, it's fine-tuned in a way maybe that we should have done in the beginning that we weren't able to do.
Great, thank you so much, Luke. And that's very helpful for both of you. My experience is a little different. I'm in Brooklyn. It's a hospital that was purchased by a large hospital system that was New York University, NYU. And at that point, you know, the hospital didn't really have much in terms of lung cancer management, not even pulmonology. So we had to start from the scratch. I always tell the story that when I arrived, I asked for a bronchoscope, and they told me, well, there's this scope, and there was a diagnostic bronchoscope looking at me. I was like, all right, what do you want me to do with this? So with that being said, it was really literally from the scratch. So it is my hope that if anybody is listening out there that, you know, you haven't really started a lung nodule program, maybe you can get some snippets from our experience and see if you can maybe avoid some of our pitfalls on the things that we did, maybe help you to build a lung nodule program. As you heard from both Dr. Garwood and Dr. Yuhico, what you do impacts the decisions and the equipment that you're going to receive. Very important to note is that if you don't tell your hospital what you're doing, they may never know. So it's important to gather the data and to actually you know, really accumulate that and then maybe present it in an organized way to hospital administration. That's basically what I did, was building a little bit, because one of the biggest pitfalls that I can find is with all these new evidence about building lung nodule programs and the importance of lung cancer screening, which by the way, we're still falling far behind what we should, is, all right, well, what are you going to do with those nodules, right? So as Dr. Garwood mentioned, we're all proceduralists, but you know, we are in different levels of procedure. So sometimes we need to go looking for small nodules, and it's important that you have the tools that are required to go after those nodules. a very important thing that it's been discussed already was how to deal with those nodules. So as many of you, I started with like formulas and looking at the patient, very important patient decision-making, meaning that explaining to the patient what they want to do. I'm in a city like New York City. One of the first things that I learned when I came here, because I was practicing in Pennsylvania, was, well, doc, there's a nodule, I want it out. And as you know, you can't take every nodule out. And there's many instances where you probably are not better off taking those nodules. And it's important to actually educate the patients that are certain nodules that are okay to take out, and there are others that are okay to continue following. So with that being said, risk stratification plays a very important role in that decision, because once you tell the patient that there's blood tests that we can make that will help us assess whether the risk for that nodule being malignant or not, that really changed a lot in our risk stratification and our introduction into our workflow on how we build it. So that's basically what we did in my institution in Brooklyn when we started, and has been so far been building. We're still lagging behind on what we probably all of us would like a lung nodule screening program to be, but certainly the tools that we have built has helped us to be where we're at right now, and we continue to grow. All right, so having said that, we're going to move to the next segment of the discussion, which is going to be, and I'm going to start with questions. What were the benefits and unintended consequences of implementing a structured lung nodule program? So I'm going to go to Dr. Yuhico, because you mentioned being in the Panhandle and all that catchment area. What do you think you would answer that question for?
I think the best thing it gave me was order. So, it's nodules, it's like dealing with nodules are like opening floodgates. So once you open your nodule program and say that you are the area that people send their nodules, you get a ton of them. And, as I always say, nodules really don't follow the rules. We're taught that, hey, if you're upper lobe and spiculated and you have a smoking history, you're probably cancer. Or if you're lower lobe and round, you're probably granuloma. But anyone who does nodules knows that that's not typically the case. And if anybody tells me they've always been able to predict a nodule, I tell them you haven't seen enough. Because any one of us who sees nodules a lot will know that prediction is difficult. So the organization of a lung nodule program was great because it's very easy for nodules to get lost. It's easy to say, like, we have guidelines and we follow them in 3 or 6 months or 9 to 12 months or whatnot. But in real life, you set the follow-up for 3 to 6 months, and well, guess what? The patient doesn't come in 3 to 6 months. And then what? And then they kind of fall out into the wind. We have a lot of people that go through the ER, they break their arm, I told they have a nodule, and they disappear. Even patients who get screened sometimes get referred out and they go elsewhere. So really, what the structure of the nodule program allowed us to do was really track a nodule from start to finish, meaning as every nodule comes in, we are able to identify them. We're able to track them from point to point, from referral to pulmonologist, pulmonologist to procedure, procedure to follow-up, and from that point to whichever treatment. And through that pathway, it was about looking at how long it took from point to point, finding the gaps that were too long and working on getting them shorter. We all do our best to speed things up. Okay, we all do our best to move things along, but really until you actually sit down and track the data and follow how many days from point to point, do you realize that sometimes what we feel is short is not short enough. And so with our program, we were able to look at that and we were able to identify, for example, it was quick to pulmonology and procedure, but it's long to surgery. And why was it long to surgery? Not from the surgeon, but maybe from a cardiac clearance. And so if the overarching goal is time from identification to therapy, then truthfully, organization allows us to put that into paper and find out each stepping stone that gets us from left to right and condense those parameters so we can truly get our patients shortened from start to finish.
Thank you, Dr. Yuhico. That's wonderful. How about you, Dr. Garwood? What do you see as when you started this?
Yeah, absolutely. I think this is a helpful slide. You kind of look at the balance here. And so Obviously, the consequence is that you're going to be flooded with nodules, and 95% of those lung nodules are benign. So you really have to figure out what your vetting process is, and a lot of that starts with how you structure your incidental nodule program and your screening. You know, what do you want to be spending your time on, and structure that. And so we specifically structured ours at HCA where we only look at 6 millimeter or greater nodules. Those are the final. You can always refer something else, but we'll look at a 6 millimeter or greater nodule, and that helped us. So we're not flooded with 3 millimeter nodules. We're not flooded with calcified nodules. We're not flooded with stable nodules. So the algorithm is really helpful to try to fine tune that. And then we really felt like because the consequence was the volume, that we needed help. So coordinators can help balance this, right? So first you want to tighten that funnel as tight as you can before we're talking about risk stratification, because there's some easy things that can be thrown out, okay? Especially if they already have a cancer diagnosis, we want to route them to the oncologist. They may still need a biopsy, but we're really looking for the unattached nodule. And like Luke said, 70% of incidental nodules in the country, Tanner's papers say, are lost to follow-up. And even if they have a primary care physician, even if they're notified. So we felt like because we have too many, we wanted to vet that. So we added parameters to what we wanted to look at. We added coordinators who then vet that with us. And so we have, we call it care assure coordinators, and they're going to review the chart before they even get to me. So once a week, I meet with a coordinator and I have a very fine-tuned evaluation. Do they smoke? What do the prior CTs show? Do they have a cancer diagnosis? And we kind of hone down what the next step for that patient will be. And then we'll move them into clinic and do that Mayo nodule calculation. We'll add biodesics where appropriate. But the consequence is if you build the program, you have, we call it boiling the ocean. So how are you going to boil that ocean and pick out just the cancers? Now the benefit, and the beautiful benefit is if you can work this correctly and identify the appropriate patients for procedure, then what you're going to get is what you see on the right, which is survival in these smaller nodules. Remember, biodesics is intended for 8 millimeters to 30 millimeter nodules. So we're talking about stage 1A disease. And I call it chasing Cheerios. I want to be able to fine tune and recognize when that 8 millimeter nodule really needs to be evaluated. And if you look to the right, you see that's 92% survival. When you build this, the other unintended consequence is if you are going to find things that are this small, do you have the foundation with advanced bronchoscopy in order to manage these? That's block time, that's anesthesia, that's pathology, that's a robot or some type of navigation equipment. Can you get an endoscopy and out of the OR? So you have to start with the end in mind. We do not encourage you to turn on nodule programs without a structure in place, but the biodesics test is a piece in your toolbox that's going to help you get to this beautiful benefit at the end, which is early stage lung cancer. And so everything that I do, each change that I make, I am looking at my stage 1A disease within HCA and within my health system. And so when I started in 2015, I remember distinctly my oncologist laughing and saying, you're never going to get to 50% early stage, stage 1 and stage 2. We just pulled our data. We're at 46% stage 1 disease, 46%. SEER database says stage 1 in the US is around 21%. So we measure ourselves and we look at that and what are we going to do next in order to move to the next step. But the unintended consequence is that you are going to be flooded. You need to be able to fine tune. You need to be able to apply the test. You also need to be able to interpret the test. And we'll talk about that more a little bit later.
That's great. That's great, Dr. Wargo. That's perfect. You know, a little bit about the benefits and intended consequences really is if really you have, as both Dr. Garwood and Yuhico have mentioned, is that you have the structure to be able to handle what's coming, right? Because it's, if you put yourself in whatever community you are in the US or outside as the person that manages those lung nodules, then you better have the structure behind it to be able to support, because you cannot do this on your own. Dr. Garwood mentioned that there's a lot, it's a team effort, there's a lot of people behind it to be able to to support following these lung nodules. Dr. Yuhico mentioned, what are you going to do if the patient doesn't show up at 3-6 months? So that's, again, when you're talking about the lung cancer screening program, you better have the support of the institution behind you so that they're ready to take this on, because it requires a lot of effort. Obviously, for the institution, there's benefits because they are looking at the potentially doing surgeries, resect these nodules. That if you are resecting, like Dr. Garwood says, stage 1A, stage 1B, everybody's a hero, right? You basically are trying to decrease the mortality in these very, very individuals that not long ago, they were very, very poor survival. So now that we have the tools and the elements to do it, but again, you have to be able to know what these are and being able to implement them. So what we did here in Brooklyn for my end is that we, as we started to grow, we didn't get a flash like maybe the other places had. We started slow. We started and implementing biodesics into very early because we saw the benefit, we saw the potential there. And we saw that it really helped us to try to define which are the nodules that we really needed to focus on to really kind of like hone on them. And rather than waiting 6 months, maybe actually go ahead and do a bronchoscopy on these patients a little sooner than later. And it helped significantly. And with the partnership like that, we were able to not only that, but once the cancer center arrived, unbeknownst to all of us, because they opened, the colleges decided to open a cancer center, and they're like, hey, do you want to be part of this? So wait, you open a cancer center? Great, but all right, sounds good. We were ready for that moment, because that moment is going to come, or if is there already in your community. So you better be ready for that. So, my next question to the panel is maybe to you. It's exactly right. It's like, how do you incorporate Notify? You mentioned that you wanted to use it early in certain appropriate cases. You mentioned that it's between 8 and 30 millimeters. That's very important. I really make that distinction very important, because some people tend to kind of like play on the extremes, and then they don't know how to interpret the results. So how do you deal with that?
Yeah, I think that's great. I'm not sure if we have, do we have the slide? I think both, but I mean, I think let's talk just about the overall test itself. I think Dr. Mercado mentioned a very important part. We have to think about the validation of the test, right? So the test is validated in 8 to 30 millimeter nodules, those who are age 40 and greater. Now, if you're going to go beyond that or outside that, it's not validated. Okay, you've got a 39-year-old, with a 7 millimeter nodule. We can't tell you how accurate that's going to be. But when we talk about the gray zone, when I go and give talks about the nodule program, I give talks to primary care physicians who think they're doing a great job. This is the slide I show. I want to help reduce uncertainty, and that low to moderate risk group, we all know, is 80% of those incidental nodules that are in that size range fall in this if you do the Mayo risk calculation. So that's a big unknown. And then after this test, and we're not going to go into the specifics, we at least can reclassify 40% of those. So we can move 35% down and 5% up. The issue is that there's still another 40% that are left in the middle, okay? And that's where people get uncomfortable, okay? And that's what we want to talk about today is, what do you do with those who are left in the gray zone? And also, how do you talk to your patients about these results, okay? So a low result, and a negative predictive value of 98% is not 100%. You don't stop following that patient. And so you want to make sure that you know that this is giving you added confidence with a 98% accuracy rate. If we go to the high risk patient, that's a 78% positive predictive value, okay? That's probably better than a physician, especially an unexperienced physician, better than a PET scan, but it's not perfect, okay? It's not a diagnosis of cancer. So being able to deal with the anxiety that comes along with this, we really want to talk through some of that tonight. But I specifically want you to think about when you go and you get pushback that this is going to reduce the number of procedures that you're doing, that this is not the thing to do. I can tell you my procedures have done nothing but skyrocket, because when I talk to referring physicians, I'm telling them I'm using more than just my brain and my experience. I'm using every tool in my toolkit to make sure if I'm going to take your patient to an invasive procedure, that I've got something that is really guiding me and reducing uncertainty, even with the amount of procedures that I've done. Like Lou said, we all need help. And adding this is not, it's not an ironclad that you have to go one way or another. But again, added information, being able to translate that to your physicians that are referring to you is very important. So Luke, any thoughts about this piece?
Yeah, I think in my scenario, it was the same. So my procedures increased a lot. And what I liked about it was they weren't just increasing, but they're increasing with higher pretest probability. Typically, as proceduralists, we've always looked for two things, volume and diagnostic accuracy, but you've always had to pick one. If you turn up the volume of your cases, you get sort of more benign. If you turn up the diagnostic accuracy for more cancer, you end up waiting more, and then get less procedures. So with the test and proper allocation, what happened with my scenario was that people were saying I was doing the right thing. I was using every test available in medicine right now to make decisions. And two, as my patients went up in volume, the percentage of cancer within those patients also went up. And so what I like about the test is that it tells you more than what you see. So looking back when I first started the program and was getting a lot of nodules, it was evident to me that, I guess I was misclassifying more than I wanted. We're all perfectionists. We all want to be 100%, and that's impossible. But we all think about, the one we got wrong and not the 99 we got right. And that was my scenario. And so for me, I looked at what I had and thought, what can I do to be better? And calculators are there, we've had them. Imaging is there, we've had it. And so I've always known we needed a better data point. But remember, at that point, we did not have Nodify lung. And so when the blood test came out, it was interesting because now, we have calculators and we have imaging. What the blood test does is it can differentiate between demographically and radiographically identical patients. So say, for example, you have 10 patients, all with a 10 millimeter upper lobe spiculated nodule, all of whom smoke, with the same family history, hypothetically. Based on what we have, if we have a radiographically identical patient, 10 radiographically identical patients that are demographically identical, we'd be inclined to do the same thing. But no 10 people are the same. They're biologically different. So what the blood test did, at least for me, is it helped me see past those 10 identical patients and make different decisions. And so if some came back indeterminate, I can come to them and say, hey, with this result, there's a 35% prevalence of lung cancer across 2 studies. The patient may be an aggressive patient or a conservative patient, but then they can make proper decision making. If they have a CDT high, then I can say 4 out of 5 chance of active lung cancer, and they can make proper decision making. Or if likely benign, then we can be more comfortable surveilling. And so now I have 10 patients with an equivalent nodule, but the blood test separates them out. And I think that was the level up for me, adding this blood test to my algorithm, because it now helped me allocate patients and help me stratify my decision making, whereas in the past it may have been one and the same thing for the same identical patient.
Look, what do you do for your when you say that you want to order a test? What is your workflow in the office or when you're seeing the patient? How do you get the test? How do you order it?
Well, there's 2 scenarios for me. So if there are the patients that come in that we see that we feel are on the lower side of risk, a lower risk, okay, where, for example, I want to do a CAT scan in 3 months, for example. Those patients, I call them the surveillance patients. It may be either that I put them for a scan in 3 months, or it may be that I may want more, but the patient doesn't want more, and they go for surveillance. So typically, when I put someone in surveillance that is within validation, and I do want to stress what Susan said, you have to be within validation, or else we're extrapolating results that are the test is not made for, But if truly within validation, when we put the patients for surveillance, we run the test, and we have the test either agree or disagree with their decision making. And so if I put a person for a scan in 3 months, for example, or 6 months, we run the test, and the test shows us a likely benign result or a reduced risk result where the NPV is over 95%, then we keep with our current plan. Okay. But if, for example, the test shows us an indeterminate or CDT positive or a reduced risk that's less than 95%, we will call them back and have that discussion with a new risk based on Nodify, and then typically push them up depending if the patient wants to go for biopsy or start with a PET. that's sort of that's the way I use it for my surveillance patients.
Do you
I will
get
also
the blood in the office, or do you send for home phlebotomy?
So we've kind of done all scenarios over here, but currently we're doing home phlebotomy. At one point we did the office.
How about you, Susan? What do you do for your program?
Yeah, so I think that we get this question a lot. So this is an outpatient test, right? So you can draw this in your office. It does not have to go through your lab. You can coordinate or contract if you have a lab that's on site, and the biodesics folks can help you. But we have our MAs draw blood, or a nurse practitioner, or half the time I'm in the office when I'm seeing the patient and I'm talking to the patient. We just get the butterfly and draw the blood right there. You fill out the form, attach that and send it in. I would really encourage you, if you look at the order form, in addition to filling out the Mayo characteristics, at the bottom of the form, it asks you what your plan is. And so when you get the result back, it also asks you what you're going to do now. So if you're trying to get some information about what the themes have been, I think that's an important piece. But we draw the blood in our office. I do rarely use home phlebotomy, do telehealth visits. I think, Luke, I love the home phlebotomy in Florida. You guys have patients all over. You're doing a lot of telehealth. So I think home phlebotomy is a great option. And then I think at the end, if you have patients or you don't have people who are great with phlebotomy or they don't feel comfortable, now we have a capillary device. You just put a little warming pad on, put the capillary device on, collect the blood in the office and send that off. And I suppose the home phlebotomist could use that as well. So this is super easy. So I think there's several options for collection there. And the form is very straightforward to fill out, and that insurance information goes with it. So I think that part makes it easy for collection.
It's important to note, in the city, here in New York City, people are very wary. So they don't like people knocking on the doors or people strange. They're a little less welcome and southerly than Tennessee or Victoria. So here in New York City, nobody likes home phlebotomy. So we actually do it in our office. The nice thing about it is that for me at least, you both have experienced this, but in my office, while we are talking to a patient, while we're discussing what the decision is going to make, I'm basically make the option says, listen, we can take some blood. That's going to also help us make the decision even further while we continue seeing what the next step, be it a PET scan, being planning for a bronch, being a planning for 3 months follow-up, because that may impact our decision. You have no idea how many times I had ordered the patient to go for a bronchoscopy for a 9mm nodule that I didn't like, and then the biodesics came. They notify came back in a negative, and as I called the patient and says, listen, the blood test came back negative. Do you still want the bronchoscopy? I feel comfortable maybe checking in 3 months, see how that works. A couple of times, and I'm not afraid to say that, oh, I didn't do a bronchoscopy. That's totally fine, because that patient will still continue following with you and actually will trust you more because it doesn't feel that you're just after, doing procedures and making money off them, right? You're just trying to make the right thing. And of the couple, I believe there were like in the last year, we had like 5 like those. We're still following and they're still stable. So that would have been a negative, right, or a low yield robotic bronchoscopy for me that we just didn't do it because probably supraanuloma or whatever. So again, it's part of the tool implementation that you can do, and it's important. The second thing that I wanted to see and I wanted to hear what you guys say is by following is you have to have. I think both of you mentioned that it's very important to talk to your biodesics rep. It's very important to have a very good relationship because they are the ones going to be handling both the sampling that may able to collect it. When it's home phlebotomy, it's a little different, but from us, making sure that they have. I'm in 2 sites, right? I'm in the cancer center, so this cancer center is not as fluent or as fluid with the phlebotomy and nurses as my pulmonary office. We order most of them, so we have seen in the cancer center a little more hiccups than in my main office, and that it's important to talk to your biodesics to come and train those nurses where you're having a little more difficulty and trying to help them out, this resolve what are the hiccups and or things that are not going as smooth as possible, making sure that the tests are up to date, that their expiration date is not beyond. We have had tests being beyond when it's in a place that are not being used very often. I'm only there once a week, so obviously I'm going to use less tests than in my main office. So making sure that that's happening. This is a great kind of like a roadmap here in this slide. You can see, how to, get the patient identification, make sure that there's a clinical workflow, educate the patient on what to expect. You have to, again, review the results with the patient. And then again, the commitment on what is like what Dr. Garwood was saying is like, all right, what is the next step? Because there's not going to be only one path, right? There's going to be multiple paths. And I think that there was a slide with her own path workflow, what she does in Tennessee. So that's important to note. All right.
Yeah, I think if we could go back to this, I think this is the hard part too. So I think it's obviously that workflow. You definitely work with your rep, work with your MAs. They'll work on getting your portal. They'll help keep your supplies up to date. But let's move to what happens when you get the test result. I think we talked about it's easier if it's likely benign, 98% negative predicted value, CDT positive. So if it's benign routine surveillance, I tell the patient I feel confident. We all are going to have, it's 98%. So if you've done 50 tests and that 51st test comes back, and then that patient 3 months comes back and there's growth and it's cancer, this is not a 100% test, okay? So if you don't have a large sample size and say it's patient 11 that this happens to, you may get a little uneasy, but we really would encourage you to follow that. And so likely benign routine surveillance is what I do. This is my pathway. This is not Biodesic's pathway. This is not HCA's pathway. I do share it with my HCA physicians, but this is my pathway, not endorsed. But I think it's helpful to think about how others think about it. And so the CDT positive, we get a PET scan, and we can get a PET scan to guide first biopsy. So we'll get a PET scan and then we'll move forward with the appropriate biopsy. The middle ground is the hard part. And in the gray, that indeterminate, and Luke's already mentioned this, I want you guys to hear this. 35% of those patients who come back with an indeterminate result have cancer. So if you get a positive, you know what to do. If you get a negative, you know what to do. If you get an indeterminate, you better be acting. Don't sit on those because of that high prevalence. So we get a PET and then we proceed with biopsy based on what we see there. And the gray zone is where people get really uncomfortable. So if it reduces the risk, what does that mean? So if you look at the test result, it's actually giving you the negative predictive value. And I talked about these numbers with my patients. And so I say it reduced your risk. Let's say it went from 17% to 11% risk. And that gave you a less than 95% predictive value. So I'm beginning to get uncomfortable. Okay, so for those patients, for me, if it's less than 95% negative predictive value, there's a 5% chance or worse. I'm going to get a PET on those patients. And then I'm going to guide my biopsy based on the PET scan. If it's greater than 95% negative predictive value, it can't tell me that it's likely benign, but man, there's probably a less than 5% chance. I'll tell the patient that. And then we talk about patient preference. If you think about that slide before, it can reduce patients' anxiety, but the patient still may be freaking out, right? Because the report, the CT report always gets us speculated nodule consistent with malignancy, biopsy recommended, and we are kind of put in the corner. But this really gives us a roadmap. And so those that are greater than 95% negative predictive value, I tell them I'm going to split the difference. Fleischner says 6 months, I'm going to do 3. Now, is this correct? I don't know, but this is what I do. Luke, I think we talked, maybe we do things a little bit similarly, and then we want to hear what Dr. Mercado does with his results.
Yeah, we do ours kind of similarly. I use 95% as well as my split. The way I describe it to patients is that, reduced risk, all it's saying is that the risk was reduced less than the Mayo calculator pretest risk. But in some scenarios, it may be reduced, but not reduced enough. Okay, so it's lower, but not low enough. And so with 95 or above, yes, I'm comfortable monitoring, but and below that, I do the same. I do a shortened gap. The other thing I'd want to emphasize that you mentioned is the indeterminate. So for a long time, I think there were a lot of questions because it was named indeterminate. And in medicine, indeterminate for us means I do not know. But in this category does not mean I do not know. Okay, it was just sort of named that. 35% based on the 2 studies, 1/3. And so if you have an indeterminate, you have enough data to go to your patient and say, you have 1 out of 3 chance to have active lung cancer. And so I would emphasize acting on it as well, the same way Susan does. What I like about this scenario was initially we knew what to do with the CDT highs, they'd stratify up, and we knew what to do with the likely benigns and stratify down. But putting a split with the reduced risk actually allows us to semi-stratify everybody. Regardless of the result, you have an action. Yeah, for those that don't know, you have to look at the back page. So there are 4 pages to the test, and at the back of the XL2, there's a back page. And in that back page, you will see a table. In that table, you will see different reduced risk results, and there is a shaded row that will apply to your patient and give you the appropriate negative predictive value for a patient. So for every patient, look at the back, and that will be able to guide you as to your sense of, am I comfortable with this result for monitoring, or is the NPV too low that I want to shorten my monitoring or get a PET scan or move forward?
Yeah, so to answer your question, Susan, what I didn't know when I was first checking this test, there was really not a lot of discussion what this indeterminate meant. So as I think Dr. Yuhico, you were the one that says we're all perfectionists. So I did not trust that, but I took that as a kind of like, all right, if this is not red, then it's either a very dark yellow or an orange. So I took it almost a positive. So I was very more aggressive with those indeterminate. And I learned that, and that's when I learned the table, and that's when I learned to look at those numbers and making sure that absolutely that a reduced risk is not the same reducing from 40 to 8% than like what you said, 17 to 11. That's if it is less than 95% predictive value, I started my senses start tingling, and I have a conversation with very big conversation with the patient, because obviously not everybody's into statistics. Probably actually 99% of people that we talk to are not into statistics. So basically my sense when I talk to that patient is like, well, listen, the test, yes, it did social results, but it didn't really help us whatever we wanted. It's very important that when you are going to do the test, you explain to the patient that this is not a yes or no, and this is not a what we remember back in the day, liquid biopsy concept, right? Oh, this is going to give you the diagnosis of cancer now. This is not what this is. It's very helpful. It's a very useful tool to kind of like assess. But again, that's why it's called risk stratification, because you have to A, learn how to interpret it, and B, apply it to the workflow that you're going to do. This is kind of like a step towards what you're going to do next. So that's why is important that we know how to interpret this test and what to do next about it. So without even talking to you guys, we kind of like do the same thing without even we kind of like learn ourselves how to deal with that. All right, well, we're almost there's a last question, but I want to be mindful of the questions that are appearing. We don't have too many questions. The questions actually that we have been answering through our discussion, so we have a little more time to answer this. Maybe Susan, you can take this one. What advice do you have for those considering implementing notified lung testing into a non-nodule program?
Yeah, and I'll be succinct on this one. I think really start with the end in mind. I think when you're talking about making an intervention, know your foundation. So know what your stage is in your hospital system currently and in your patient population, and then really think about what is the impact you're trying to accomplish. You're trying to get more biopsies on patient with malignant disease and not benign disease. And you're trying to get earlier stage disease. So measure your stage before and after, and then look at the percentage. We were talking before we started, what's a healthy number? So if 50% of the time your biopsies are benign, that's probably not healthy. So is 70% healthier, 75%? We all know that we're going to have sarcoid. Well, I mean, I'm in the South. I got a lot of histo, that kind of looks like a duck. Patients get anxious. The CT scan and PET scans say cancer. So we all are going to be doing some benign disease, infections, other things that we need to do biopsies on. But think about what a healthy number looks like and be able to go back to your administration and to your referring physicians to be able to say that you're using risk stratification and biodesics for your patient's betterment and for the program's betterment. So measure your stage, measure your percent malignant, and think about how that's going to impact you. And so if you have questions, I think don't push back from the test. Call and ask one of us or speak to somebody. We'd love to connect you because we really think this really will refine your lung nodule management.
How about you, Luke? In a few minutes, a few seconds, actually. What do you say about Nodify?
I would say the biggest thing is there is a learning curve to it, but this test will give you a lot of information and really level you up if you commit to it. So commit to it, learn it. It's not a binary test. It's not a yes or no. We all want it to be 100% accurate. It's not, but you will certainly be better with this than we were without it. So learn it. Go through it, work with your rep, and if you get the hang of using this test, you'll find that you will be doing things a lot better than we ever did before blood came into the lung nodule world.
For sure. That's I think we all can agree on that. That's a great way of putting it. All right, I'm gonna open ourselves, if all the panelists are okay, to questions. We've been getting some of them. The first question actually we answered already because we did discuss. I'm very proud of us that we went through a lot information in very little amount of time. The second question is, Dr. Yuhico discussed the importance of reducing the time along the pathway of evaluating nodules. Is there any data that the rapidity of the evaluation is associated with poor outcome, or is it more important to be comprehensive as referenced by Dr. Garwood? I think I'm gonna take this one because I think I listened through both of you guys. I think that those things are not opposed to each other, meaning like you can be comprehensive, like Susan said, and you can actually be fast, like Luke said, because if you do have a workflow already in your path and you already know how to guide that patient and you have an established advanced bronchoscopy program, you're going to get that answer, and you can get that answer right away. I mean, we can probably get biopsies in less than a week for those patients if they need it. And what the Nodify does, I think, is actually helps you to get there. Because if you get a positive result, instead of waiting 3 months, you can do that biopsy next week. And so that, and as Susan very well pointed out, is like you want those patients, those 1A, 1B patients, and that the data is there. The earlier you diagnose, the earlier you treat those patients with surgical resection or whatever form you have, those patients are gonna fare better. Anybody has a different opinion or any other?
I think the concern is, right, you're stalling, right? You're wasting time. I could just get to a biopsy tomorrow and that's the right thing to do. And that is not the right thing to do. I think you have to, like we said, this is a structured program. Okay, so order the test, put them on for a week with the telehealth to go over the results, okay? Have a PET scan waiting in the queue, you can cancel the PET scan. Have a bronchoscopy booked for 2 weeks later, you can cancel the bronchoscopy. Have a structure, okay? Already pre-authorize a PET and have it waiting in the wings, you can cancel it. So if you get structured and you get organized, everyone on your team will know if this result comes back, I'm gonna know. And I use my nurse practitioner to help as soon as that result comes in, especially if we get a hot one and a CDT result comes back high, we know what we're gonna do. We're gonna go ahead and get that PET and get that patient on the bronch schedule. So stay structured, and if you're structured, then you can be efficient.
Perfect. Luke, anything that you wanna mention to that effect?
Yeah, I think Susan said it all. You're organized, make the system work for you. If you can lay it out while you're still small, lay it out in order. As you grow, that structure will stay. So when you are doing sort of 30, 40 cases a year, set it in place so that when you're up to 200 and 300, you have the same pathway moving forward.
Perfect. There's another question here that says maybe this is outside of the scope of this talk, but could you help me understand why this cannot be done through hospital lab blood draw as any other blood tests?
It absolutely can be done through a hospital lab. So it's an outpatient test, so that's not a problem. It just, again, where is that lab? But this is exactly, if we go back to that, talk to your rep, what makes the most sense? They'll come in and basically do intel. What's going to work for your lab? Who can draw blood? Is home phlebotomy better? What lab services do you have available? So absolutely you can do that. For us, it made more sense to do in the office instead of going through contracting with our lab. But absolutely you can do that, and the reps will guide you down that path.
Yep, absolutely. Okay, and then I think that the other question was, how do you make the decision to actually order? I think we already talked about that. A question that I had maybe to Dr. Garwood is, you mentioned building the lung nodule program to kind of help you get the tools that you need. Is there any particular thing you want to share with the audience about what was your experience doing that?
Yeah, I think, like I said, start with the end in mind. And if you don't have data, for me, I can't really get my health system to move forward without showing them objective data. So the health of my program, the way I get more things is to look not only at stage, but conversion of my advanced bronchoscopies to surgery or SBRT. So we measure those routinely. We look at those quarterly. We look at that conversion to Da Vinci surgeries. The higher that percentage, the healthier my program. That means that more of my biopsies are on cancer, they're on earlier stage. And so for me, if I want a second robot, which is what I'm asking for right now, I can show them that my conversion rate for my robotic surgeries is over 40%. I can show them that my stage has jumped up 10% over the last 3 years in stage 1 disease. And that's how I get more things. And so if you're going to be able to measure stage and conversion to surgery and SBRT are helpful. If you do have advanced bronchoscopy programs, regardless of vendor, most of them, especially the robotics, have data collection. Let them work for you. Okay, same thing with biodesics. They can help you with data. They can help you present data and talk to your referring physician so that they understand how they can responsibly handle. One of the things we didn't talk about is they can give you kind of a violin plot of your results, and you can show that. And I would encourage you to talk about that on how many of the tests that you did were reclassified to low or high, and what was that impact. But for me, the way I get more stuff is to measure measure my early stage disease and my surgical conversions in SBRT.
Yeah, what hospitals want to see are basically the numbers. They actually want to see hard data showing them that they have return of investment for what you put in. So same with me, like I was a very small place, and now we have full support all year. And we had to do the same. So we proportionated the amount of procedures we do, the proportion of diagnostics. We looked at the increase of surgical referrals that stem down proportionate to the increase of procedures. And we actually, yes, we went to the robot people, and they were able to get sort of a demographic of how many procedures we did for EBUS and for, at least it was Super D back then, and look at the ROI for each procedure and proportionate to how many surgical referrals we got in the last year and then last 2 years. And then they sort of laid it out. So if you give us more, we can get these more, and then they make more. But the administrators, they need numbers. But we have tools. So biodesics, the device companies, they can get all this data for you. So I would reach out to them and have them work with you to lay it out for your hospitals.
A question came in that maybe Dr. Yuhico, you can answer since you were talking. How many times are you allowed to order these tests?
I believe that at least from insurance, you can order it every 3 months, but I don't do that. Typically I order it just once. The scenario, at least is my practice pattern, the scenario where I may order it again is if, for example, I have another nodule pop up, or I have a several nodule patient, and especially if it's a patient with on and off nodules. So yeah, I get these granulomatous patients or sarcoid patients here where they have on and off nodules. But because of my demographic, we have a very high cancer population. So I know that if I had 50 patients with on and off nodules, some of them will develop cancer. So I typically use the test in that scenario. I may repeat the test in that scenario, but typically I don't repeat it.
Same.
I don't know if Susan sees the same. Yeah.
Same. Yeah, I think the waxing and waning are always frustrating for me, but we've all had that patient who had a waxing and waning, and the third time a nodule came up, that was the cancer. So yes, I've used it, and it told me not to worry. The next time I scan them, that nodule's gone, but there's a new one. I'm like,
Right.
Now what?
Right.
So yes, that's the scenario I use most commonly.
I see a lot of bronchiectasis, and bronchiectasis, as you know, can accumulate a lot of mucus.
Mhm.
Mucus looks like nodules, especially peripherally. So if that patient comes back and then has a new nodule, I tend to not do 3 months look. I tend to extend a little more, maybe. I almost see it like a CAT scan radiation, right? I don't want to confuse myself, so I push it as much as possible. But yeah, you don't want to rely on this test like almost other tests that you can check it every now and then. So you have to rely on if there's a new answer that you want to ask. That's how I would look at it. So new nodules is the answer to that. The question, maybe Dr. Garwood can answer this. Do you use tornado coil at the same time biopsy of nodule for lung nodule marking as a routine or case-by-case basis in your algorithm?
Yeah, I'm super blessed. I have my thoracic surgeons right in the hospital with me. They perform, I can perform procedures daily, and they are in the OR, 3 days out of the week, almost 4 days out of the week. So we just roll the robot up and we do dye marking at the same time. Most of us aren't that blessed, right? So a lot of our HCA hospitals, we have procedure lists, but the surgeon's not on site there. So, soaking a tornado coil is a great way. It's an expensive endeavor, but I can tell you if your hospital wants that surgery, then a tornado coil being shipped to you is a great thing to do. So if you have something that looks like a duck, quacks like a duck, and you want that thing out, and it's a smaller nodule, that's a great option. If you are in the hospital, it's an expensive option if you have a surgeon right there. So think about the cost benefit ratio, but that is a great option if you're in a hub and spoke model, and you can do that up to 2 weeks prior.
All right, perfect. So we're almost out of time. Maybe Luke, you want to mention if you use coils before finishing up? We have the slide that tells us almost like in the Oscars that our time is up. The clock coming down for future. Please, yes.
Become a member.
That's right. As the chair of membership, I have to tell the audience that become a member. There's this webinar available as well as many others with great speakers available to you as a member of the Society of Advanced Bronchoscopy. We have recently met with Dr. Garwood and other members of the committee, and we have great ideas coming down the pipeline to help our members and get them involved. So please look us up on the website, but also on social media. We're in LinkedIn, Instagram, Twitter, and other social medias you may have that I don't. So I tell my fellows sign up. For the fellows is free. So really, kind of like a few benefits that you obtain from being a member of the Society of Advanced Bronchoscopy. You really get learning, especially when you're starting up. That's why it's free for the fellows, because we really are looking to help those fellows getting into what we do as advanced bronchoscopies, refining skills that they may have, learn new techniques. Really, it's about also networking. We met a lot. There's very few of us, but we don't talk to each other, or we don't meet each other as often as we would like. So it's a great space to collaborate, learn about job opportunities that you may not find out if you just Google it up. You won't find, and also learn about what people is doing on the other side of town that you may not even know. Also, we highlight events that may be of interest to you with CME opportunities, and we are a young society, and we're always looking for young members and older members as well to get involved, and opportunities for committee membership are there. So look us up in the website, and I will leave it for both our panelists to see any last words.
No, just appreciate both Biodesics and SAB. I think Dr. Mercado really said it best, is that we really want to be transparent. We have been where you are and are so grateful for the opportunity. So thank you all for joining tonight. Luke?
Yep, thank you all for being here as well. I look forward to hearing your stories, maybe meeting some of you. We are your resources. Your Biodesics teams are your resources. use them, use us, whatever we can do to improve lung cancer survival. We're all in this together. So let's go forward and do it.
Well said. Thank you very much, Dr. Garwood. Thank you very much, Dr. Yuhico, Society of Advanced Bronchoscopy and Bioethics. I'll see you soon.
Thank you everyone for joining tonight's webinar. And once again, thank you to our sponsors, Biodesics, and we look forward to seeing many more of you at the continuation of our educational and sponsored webinars. Have a good evening.